So good morning, everyone. Thank you for joining us.
Are you muted?
Your own audio is muted and you won't be seen on video. This presentation is being recorded and will be available on the Institute on Aging and Lifelong Health YouTube channel. Dr. Booi is going to do her presentation, and this will be followed by a Q&A session at the end. If you have questions or comments for her, please add them to the Q&A using the Q&A button at the bottom of your screen. I am Joanne Miller. I'm the research manager at the Institute on Aging and Lifelong Health at the Institute on Aging at the University of Victoria. Thank you all for attending today's event. Before we get started, I'd like to begin by acknowledging with respect the Lekwungen peoples on whose traditional territory the university stands, and the Songhees, Esquimalt, and Wasandic peoples whose historical relationships with the land continue to this day. Today's speaker is Dr. Laura Booi. Dr. Booi is a gerontologist and research fellow at LeedsBeckett University's Center for Dementia Research in the United Kingdom. She has established herself as an expert in co-design and public patient involvement methodologies focused on brain health ventures. She is committed to brain health research and education through her work as a Senior Atlantic Fellow for Equity in Brain Health with the Global Brain Health Institute, as the co-lead of the OECD's Working Group on Brain Health Diplomacy, and through her work as co-founder of the World Young Leaders in Dementia. Dr. Booi is the recipient of a UK Research and Innovation Catalyst Award for Healthy Longevity and Global Brain Health Leader Award for her research with marginalized populations and brain health. She received her BA from Vancouver Island University, her master's from UBC, and her PhD from SFU. When she is not conducting research, she is running in the parks in Newcastle upon Tyne in the UK. Welcome to Brain Health and Healthy Aging. Dr. Booi, over to you.
So good morning, everybody. Thank you so much for letting me speak with you today. So my name is Laura Booi. I'm a research fellow at the Center for Dementia Research at LeedsBeckett University. I'm going to say a little bit about myself and a bit about my background, and then we'll go into the agenda of the presentation. I would like to talk for under an hour, and then, feel free to drop by or drop in and out, however you please. We're all on Zoom. I know I have a number of colleagues and family and friends attending this from Alberta and British Columbia. So thank you very much for actually being here and seeing me present. And I look forward to your feedback very gently later on in the presentation. And if anybody can now put in the chat function or in the Q&A function, if the slides are looking okay and if you can hear us okay, just so we can have a little bit of feedback that we are doing this all right. Okay, brilliant. So I can't see the chat as it goes, but I have my colleagues who are looking at it. So, okay, so welcome. My name is Laura Booi. I'm a social gerontologist. What that means basically is I look at how society is aging and how we can do better in different societies to support an aging population. I also work on brain health research and dementia research. So how to make the quality of life better for people who are currently living with dementia and how to prevent or reduce your risk of dementia later on in the future. I am from Vancouver. Well, originally I'm from Slave Lake, Alberta, and then from Vancouver Island for all my memory. I recently moved to the United Kingdom. I moved to Newcastle upon Tyne in the north of England in March 2020, because that was a terrific month to be moving anywhere, let alone a new country. So I'm a Senior Atlantic Fellow with the Global Brain Health Institute. They're based in San Francisco and at Trinity College in Dublin. The Global Brain Health Institute combines 300 to 500 fellows who are all focused on brain health, risk reduction, and dementia work. So they're predominantly from low and middle income countries. And what happens is a cohort of about 30 people are situated for a year, either in Dublin or in San Francisco. We go through a curriculum together. We do rotations in different healthcare settings to really learn about what does dementia care and brain health research look like in an international environment. So we did such things as going to long-term care facilities in Ireland, focused specifically on people living with Down syndrome. We did rotations in clinics with people who were consultant psychiatrists in inner city Dublin. So different different techniques to learn in a more holistic way of what does brain health clinically look like and what does it look like in the community. The UK Research and Innovation Network are the funders for me being allowed to be here. I currently have a Catalyst Award from them looking at developing a peer mentorship program for people living with Lewy body dementia. I'll mention that briefly in a little bit. And LeedsBeckett University are my employers, and I work at the Center for Dementia Research with them. Now, so the agenda today, I just wanted to go over what is dementia. So there's a lot of myths and misconceptions surrounding what is and what isn't dementia, what causes dementia, what cures dementia, anything like that. I also wanted to go over, so there's two portions really, dementia overview and then risk reduction, and then we'll discuss some more positive and creative things that are happening in the research worlds that I'm involved in. And I just wanted to demystify what is the brain, that it's not some magic item, that a black box that people have no idea what it's about. There's a lot of really clever people who are working on brain health issues and research. I have the fortune of knowing quite a few of them. Okay. So where I work is the Center for Dementia Research. There's 6 overarching themes of items that they work on. So dementia education, post-diagnostic support, social care, hospitals, cancer and dementia, community support and engagement. My team is a brilliant group of individuals who, if there's anything specific that you're interested in there, if I can link you in with those people and you can have a better conversation about that with them. So for instance, if you're interested in some work looking at what is it like to live with cancer and support people with dementia, or live with cancer and also have dementia, they've developed some brilliant educational material in that center. I wasn't involved in that project, but I'm happy to link people up. With anything that I say today, if there's anything you'd like to know more about, and if it's not my own project, please let me know and I will send an email. And I think my email is at the bottom of somewhere on this slide. So I'm reachable. So the first part of this is the dementia overview. Just one sec. Where are the slides? Good fun. Okay, good. So this is, as a gerontologist, this is drilled into our heads that the population is aging. I'm in the Institute of Aging and Lifelong Health right now. I worked at the gerontology department at Simon Fraser University. So the fact that the population is aging isn't a big, it's not a big surprise to anybody. Oh, just one sec there. So in 1950, there was 8% of the population that was over the age of 60. In 2000, there was 10% of the population over the age of 60. And then in 2050, there'll be 21% over the age of 60. The reason that I bring this up is not that the demographics of the world are switching or are shifting. Recently, I think it was 3 or 4 years ago that it was the first time in Canadian history there was more people over 65 than people under 15. And that was a big media thing there. But the reason I bring this up is that age is the biggest risk factor for dementia. So to have a conversation about dementia and about what are risk factors for dementia, one of the biggest issues is that the population is aging, and ultimately age is something directly linked to dementia. And I'll talk about that more when I talk about risk factors. So defining dementia. So dementia includes a number of different terms. It's described a set of symptoms that includes a loss of concentration and memory problems, mood behaviors and changes, and problems with communicating and reasoning. Those are the overall really broad symptoms of dementia. If you look on the right there, that pie graph, there's the different types of dementia, and you'll see that Alzheimer's disease is the biggest component of dementia. Right now, Alzheimer's disease, it accounts for most cases of dementia. But I've been at conferences where people talk about Alzheimer's disease could be up to 30, 40, 50 different types of dementias. We just don't know the nuanced variables involved in diagnosing and defining it at this stage. We're still learning. But Alzheimer's type dementia is the biggest type of dementia. We see that Lewy body right there, where is it? Is about 4% of the cases of dementia. Now, what's interesting is that it's actually predicted to be perhaps 10 to 20% of the cases of dementia, but because Lewy body disease is so understood in the clinical settings, that often what happens is people get diagnosed with Alzheimer's or dementia just because there isn't information about Lewy body dementia. So dementia results from a variety of diseases and injuries that primarily or secondarily affect the brain. I'll talk about risk factors for dementia, but there isn't one gene, and there isn't one traumatic brain injury, and there isn't one variable that causes dementia. It's a combination of things that affect this organ. So just like your liver or your skin, if you have skin cancer, or if you have liver failure, it's a number of different lifestyle, genetic, environmental components that affect your risk of dementia. Just one sec, I have to move myself. Okay, terrific. So the numbers are a bit grim when you look at them, but that's okay. It's just a lot of opportunity for us to figure out how can you live the best quality of life with dementia. So currently there's 55 million people who have dementia. I think there is the population of Canada, 44 million right now. So there's more people living with dementia than people living in Canada. Something I really want to highlight is that 60% of individuals living in dementia are in low and middle income countries. So oftentimes we have individuals who are in the care setting who come to work in high income countries from low income countries. But in reality, there's more cases of dementia in those settings than there are in high income countries. As the proportion of older adults in the population increases in nearly every country, so almost every single country, the population of older adults is increasing. The number is expected to rise to 78 million, so almost double by 2030, and almost triple to 139 million by 2050. So huge amounts of rates of dementia in the coming future. So alongside the numbers, there's also the social and economic impact. So dementia has a significant social and economic impact in terms of direct medical care, as well as social care and the cost of informal care for caregivers. I'll talk about that in just a second. I'm sorry, these numbers are US numbers, but in 2019, the estimated total global societal cost of dementia was $113 trillion. And these costs are expected to surpass 2.8 trillion by 2030. As both the number of people living with dementia increase and the care costs increase, and then the cost of the informal carers and quality of life increase. The World Health Organization has a really important dementia fact sheet I linked to right there if you'd like more information. Also, at the end of this presentation, I've collated British Columbian, Canadian, and international resources that I thought maybe if anybody would like more interest of that, you could take a look at there. So two really important myths around dementia that I want to get out of the way right away is that 2 out of 3 people still think that dementia is caused by normal aging. The Alzheimer's Disease International did a survey in 2019, and they had about 10,000 individuals, not just people living with dementia, but it included people living with dementia, dementia carers, general publics from around the world who did this survey. And it was looking at attitudes and stigma around dementia and misconceptions. So the fact that just 3 years ago, they found that 2 out of 3 people who are, know a bit about dementia still think that it's caused by normal aging is a little bit disheartening, but again, just areas for education and improvement. And also 1 in 4 people think there's nothing we can do to prevent dementia. That is absolutely wrong. We never want to put the onus on someone living with dementia that they could have done something to prevent their dementia. That's not what we're saying at all. But there are things that can be done to reduce your risks of dementia. So the fact that 1/4 of the population isn't aware of this or isn't aware of brain health or healthy brain health living is, it's something to work on. I'm sure everyone here, you attended some lecture entitled Brain Health and Healthy Aging, so you guys probably already all know this anyway. This is a really good resource by Alzheimer's Disease International, the same people who did that survey. They are basically Alzheimer's Disease International is this massive umbrella organization based in London, but they oversee Alzheimer's associations and Alzheimer's societies across the world. So they really are the global voice of education and research for dementia. Even though they're called Alzheimer's Disease International, and there's more types of dementia than just Alzheimer's disease. But anyway, this resource right here, Women in Dementia, a global research review, is absolutely brilliant. It talks about how dementia globally disproportionately impacts women. So 65% of total deaths due to dementia are women. And also disability adjusted life years due to dementia are roughly 60% higher in women than in men. Additionally, women provide the vast majority of informal care for people living with dementia, accounting for 70% of all care hours. So if you pull back there, what that's saying is that if you're a woman, you're more likely to get dementia than a man. If you're a woman, you're more likely to have a harder time with the dementia than a man. And if you're a woman, you're more likely to care for somebody, a loved one, mother, mother-in-law, aunt, who's living with dementia than a man. So the situation incredibly disproportionately affects women than men. Interestingly, individuals will ask why is this the case that dementia affects men and more than men? And often the quick answer is, oh, well, women live longer than men, but that's definitely not the real answer. That is one variable, but like we said before, there's many variables that impact this. So there's some interesting research looking at estrogen and lack of estrogen after menopause that's linked to different forms of dementia. But the completely honest answer is just that we have not done enough research looking at the effects of dementia in women and getting dementia as a woman. I have a really brilliant colleague, a Romanian individual named Stefania, who does really great work with women and dementia and looking at that from an economic perspective and a global perspective. If anybody's interested in me linking you up with her, I'm more than happy to do so. Another thing, and then I'll get off the high horse about gender differences in dementia, but I wanted to throw in this slide. The slide isn't my slide. I lifted it from the Women's Brain Health Project, and you can see their logo in the back, so I have not plagiarized anything. But this slide looks at sex biases for brain health issues. And so I just wanted to point out that if you look on the right, the blue side, I know gender-based colors, but what do you do? On the male side, ADHD is more common in males. Autism, dyslexia, stuttering, different forms of schizophrenia are more common in males. Late onset schizophrenia, anorexia, bulimia, multiple sclerosis, and dementia are more common in females. So it's not that one gender, and I know gender is on a spectrum, has different areas of the brain that are weaker or stronger than others. It's just that there's different issues that affect depending on what gender you are or where you are on the spectrum. In this slide, I know it's a lot, and I just want to point out that if you look at the different types of dementia, so if you look at Alzheimer's disease, the orange bubble on the top, it looks at dependence and independence, and then it will look at mental and physical symptoms of dementia. So for Alzheimer's disease, you may be more dependent if you're living with that, and you might have a greater amount of mental issues. Whereas if you have something like Parkinson's disease, you may be more in the middle of independence and dependence, but you might have way more physical issues than Alzheimer's disease. And Parkinson's disease type dementia is what that would be there. And Lewy body dementia falls under that umbrella. So obviously you don't have to know all of this, and this is being recorded, and if you ever want the slides, just let me know, not a bother. A type of dementia that I'm incredibly interested in is Lewy body dementia. It's again why the UK Research and Innovation Network, thankfully they paid for me to do this project looking at peer support and Lewy body dementia. So Robin Williams died with Lewy body dementia many years ago, and I think many of us, grieved the loss of Robin Williams and how he died by suicide. But there's a really brilliant documentary about Lewy body dementia that Robin Williams' wife, Suzanne Williams, funded, looking at Lewy body dementia and how it affected Robin Williams' life, and why ultimately, because of the symptoms of it, he chose to die by suicide than live with Lewy body dementia. A colleague, Kevin from Ireland, wrote this book, I Am Kevin, Not Louie. He is a brilliant human. I see him once a month on Tea Time with Louie, which I'll talk about in the next slide. But one of the important things about Lewy body dementia is the non-visual hallucinations and the visual hallucinations. So as I was telling my siblings on the weekend, they probably forgot, but I'll say it again. Somebody with Lewy body dementia once described it as the visual hallucinations will start off by seeing mice run across the ground, and then the mice will become cats, and then the cats become dogs, and then the dogs become children, and the children become people, but then the people then may become deceased people, and then you start seeing things that are really vivid and really traumatic, and then you have auditory hallucinations as well. So it's that is one example of somebody's visual hallucinations with dementia. So with Lewy body dementia. So incredibly traumatic, really upsetting. but I mean, it doesn't end there. Like we'll talk the next slide. So basically, if you want to learn more about Lewy body dementia, I highly suggest Robin Williams' wife's documentary. It's a like 45-minute pleasure video. Not pleasure, I mean, it pulls at the heartstrings, but it's really well done. Or buy my buddy Kevin's book, I'm Kevin, Not Louie. He's a gorgeous human who's very Irish and just talks about his experience with Lewy body dementia. So the reason I see Kevin once a month is this thing called Tea Time with Louie. It happens once a month. The time zones switch so that sometimes individuals in the PST time zone can come and sometimes individuals in Australian time zone can come. So if you want more information about that, you can Google Tea Time with Louie, or like, of course, send me an email. The Lewy Body Society International is the one who puts it on, and Lewy Body Ireland. So every month there's 40 to 60 people who join. It's people living with dementia, it's carers of people living with dementia, it's family members. And then alongside that, there's clinicians and physicians who attend, and researchers such as myself. So individuals with Lewy body dementia can say things like, you know, my back is really hurting, I have these symptoms where I can't sleep. And then other individuals with Lewy body will be like, hey, Laura, yeah, I have the same thing. And what my physician told me was that that's coat hanger syndrome, and it's because you're walking with a stooped gait. And then the physicians on the call will say, yeah, I can confirm this is something that's very common with my patients with Lewy body dementia. So it's not an area where you can get a diagnosis or you can get a prescription or anything like that. It's just a really beautiful informal setting of connecting people living with Lewy body dementia. The project that I have funded by UKRI is building off this, but connecting individuals diagnosed with Lewy body dementia. So if I was just diagnosed with Lewy body dementia, I'd be looped in with Joanne, who's been living with Lewy body dementia. This is in a fantasy world for let's say for 5 years. And she's gone through a curriculum to really help me how to live best with Lewy body dementia. So how to avoid situations of wandering, what are my human rights, how to access resources and support, what is stigma associated with Lewy body. And so I would go through the curriculum with her for about 6 weeks. We'd meet over Zoom once a week. And then I would either join a bigger group like Tea Time with Louie, or maybe Alzheimer's Disease International. Dementia Alliance International, the largest patient advocacy group of people living with dementia. Okay, so that was a little bit about Lewy body. We're moving along. Just very briefly, I want to touch on conditions that are similar to dementia, but they're not dementia. And there's many conditions out there that can easily be confused with dementia. Looking at the participants in the webinar today, I know this might be common information for a lot of you, but just getting it out there anyway. So most common is delirium and depression. Delirium is an acute confusional state. It's a treatable condition. There's many symptoms of delirium. Here are some of them now. Often what will happen is somebody will come in with a urinary tract infection or be super dehydrated and come to the hospital. And maybe that individual will get diagnosed with dementia, but actually it's acute delirium. And delirium could happen from a small amount of time, minutes, hours, to months, years, and I believe years as well, but I should ask my sister, who's a nurse, Emily, about that. She knows more than I do. So delirium, and it's also that pink elephant delirium beer, that's based off delirium. And this is, so pink elephants on the Disney Dumbo is also based off delirium. So it causes infection, high temperature. Some medications can cause deliriums as well. Depression is also a really interesting one, and depression in instances linked to menopause as with women is really interesting to look at what gets diagnosed as dementia, or what gets diagnosed as depression, or what gets diagnosed as a symptom of menopause. So interesting work will be happening soon about menopause and dementia. It's not my area, but it is a really interesting area to look at. So depression can also be looked at, it can be thought of sometimes as a dementia, but it's definitely not. And in some instances, it can be treatable. So I just want to touch on fear of dementia. So there's a huge amount of stigma associated with dementia. On this massive survey done by Alzheimer's Disease International, almost 80% of people across the board, across the world, worried about getting dementia. And another study looking in Europe, looking at fear of items, looking at dementia was higher than cancer, stroke, or anything else, which is often the case, right? And with my previous work looking at nursing homes, individuals were more afraid of going into a nursing home than actually end of life. So there's a real area that there has to be improvements, especially with the aging society. And I haven't seen The Father, but I mean, I heard it was a great movie. I just have a problem sitting for, I just haven't watched The Father, but I will watch it. I hear it's a great dementia movie. But on this review of it, I want to point out, so Anthony Hopkins occupies the screen with like King Lear in a cardigan in The Father. It's a kind of horror film, if horror is also a tragedy. It's not scary horror, but it should scare the stuffing out of anybody who has contemplated their own failing memory. That prospect is far scarier than anything Freddy Krueger ever threw at us. This is a review less than a year old. And obviously I don't know the individual who reviewed it. Obviously this person is not a dementia researcher, advocate, because they wouldn't say something so absolutely stigmatizing. I know that many cases of dementia are horrifying. Living with dementia can be absolutely horrifying, but propagating this type of narrative as the only narrative of living with dementia does more harm to society than good, and definitely does more harm to individuals who are currently going through the dementia journey. At any point in this talk, if I try to romanticize dementia in saying that increasing quality of life, I'm not negating the really difficult and horrific times that many individuals have. I've been a dementia researcher for 13 years and an advocate for just as long. So I in no way mean to minimize that situation. So my apologies if it ever comes across that way. So this work is done by my dear friend and colleague, Dr. Francesca Farina. She's based in Ireland at Trinity College in Dublin. She did work looking at fear of dementia, and she's continuing to do work looking at fear of dementia. The articles, that's the article there. If you can't access it, just send me an email and I'll send you the PDF. So fear of memory loss, it predicts an increased memory failure and lower quality of life in older adults. And this is with a preliminary study. She's doing a much larger study looking at this now. So basically the gist of this is that if you are already afraid of memory loss and already afraid of fear of getting dementia, you will react in a way with your daily acts of living that will then perhaps put you at a greater risk of developing dementia in later life. So basically, I guess the take-home message is don't be afraid of developing dementia. Don't let it affect your daily life and what you go out and do. If you do have memory loss, and if you are perhaps on the spectrum of having memory loss or cognitive incapacities, the people around you who love you and support you could be made aware of that. And if they're worth their weight in salt, they will meet you where you're at and support you as best they can. And if they need any more information about how to do that, I have a bunch of resources at the end of this lecture. So we talked about Francesca, who does brilliant work. I can't say enough good things about that woman. I wanted to talk about another woman's work, Dr. Gracie Jackson, who's a clinical psychiatrist in the US. She wrote this book about 10 years ago. She's writing a new book now. And I was really surprised to see that it didn't get the media attention that I thought it should get. Not that I'm a pharmacist and not that I'm a clinician, but I am a researcher and a brain health expert. And this book highlights how anticholinergic drugs may cause vascular dementia. So there's emerging evidence that the use of these drugs might cause vascular dementia in people ages 50 and older who'd otherwise not be expected to get dementia. And so this is, excuse me, not a genetic type of dementia, but what it is saying is that often people could be on chronic medications, not all medications, but they could be on chronic use of medications that maybe they don't need to be on, that could actually be affecting their brain health negatively to the point of putting them at greater risk for certain types of dementia in later life. So like I was saying earlier, that the brain is an organ just like any other organ. If you're taking a bunch of medications, you have to think about your liver and how those medications affect your liver. It's the exact same thing with your brain. If you're taking a bunch of medications, you have to think about how those medications could potentially affect your brain chronically in different stages of your life. Again, don't go off your medication because I said this, but maybe do some research and talk to your physician about it, or pick up this book or email Dr. Jackson for more information. Yeah, she's lovely. So there's a number of myths about medication. I mean, where was the one? The one on the right with the BBC, that was just a few months ago about Viagra may be useful against Alzheimer's disease. And this stuff is always like, it's always coming out that there's this random medication. I mean, there was this cannabis advocate named Mark Emery in British Columbia, and I got into a heated conversation with him once because he was trying to convince me that marijuana was the cure for dementia. And I mean, like, fair play, I like, this will come to us as a surprise to my family, but I definitely am a marijuana advocate, but I am not going to say that marijuana is going to cure dementia. And I think that is incredibly irresponsible for anybody to say that one thing will cure dementia. Aricept for dementia is one of the very few drugs that's been on the market for dementia with mixed reviews. UVic Center, Institutional Aging and Lifelong Facility that I'm at right now, and I know I got that name wrong. It's on the pen here. Institute on Aging and Lifelong Health, my apologies, has done some really brilliant work looking at Aricept and cholinesterase inhibitors and dementia and their effects on caregivers. The new drug, aducanumab, which I know I butchered, and I was even listening to how to pronounce it on Google about a dozen times this morning, is not legal in Europe, but it has been made legal in the US and I believe in Canada as well. Really, really mixed reviews about that. It's not a silver bullet. I mean, people are still working on finding things that will support people with dementia in later life. There's brilliant researchers and a lot of philanthropy money looking at perhaps we can develop a vaccine to prevent Alzheimer's in later life. So not all types of dementia, but perhaps the most common forms of dementia in later life. That vaccine is clearly not out, and like the first time I heard about it was just a few years ago. So, I mean, there's a lot of work happening, but people are putting a lot of money and time and human energy into finding solutions. So no cure yet, but please be aware of all the myths out there about what could possibly cure dementia. Yeah, don't go spend your money on a bunch of things or do buy expensive brain health games or anything like that. Be good to yourself. Really, we'll talk about the risk reductions of dementia you can do in just a minute. So living with dementia, how are we doing for time? Oh, we're doing great for time. And then we'll have a conversation, or you can ask questions and we can get at them, because I'm sure I've said things that are discussion worthy. You know what I mean. So living with dementia, there's many signs and symptoms of dementia. I'm not going to go over these, but they can range from auditory and visual hallucinations to memory problems. So memory is often the go-to thought of when someone thinks about dementia, memory, Alzheimer's disease. But there's different forms of dementia, such as Lewy body dementia, where memory actually isn't the main symptom. It would be the auditory and visual hallucinations. Or with Parkinson's type dementia, it would be the physical symptoms. So memory is just one of the symptoms that could happen with some of the forms of dementia. It's not always the case. So this is a dear friend and colleague, Kate Swaffer from Australia, brilliant book, What the Hell Happened to My Brain? She is one of the biggest living advocates for dementia. She's been at the World Health Organization many times, one of the founding individuals for the Dementia Alliance International Group, the largest group of people living with dementia around the world supporting each other. She describes, she trademarked this word called prescribed disengagement, that when she went to go, she had a dementia diagnosis and she has young onset dementia. So she was quite young when she was diagnosed. In her 40s, she felt the physicians were, well, she didn't feel, the physicians basically said, go home and get your end of life affairs in order because this is your palliative sentence and see ya, kind of a thing. So she was prescribed to disengage from society, that once she had dementia, she was no longer a valuable component of society and there was no room for her to grow and develop as a person and to add to her family and friends and her own well-being. So she really pushes this post-diagnostic support in dementia. She says we all must empower and re-enable people with dementia to continue to live and remain independent for as long as possible. So when I first moved to England, I moved to work on the Pride In project with Professor Dame Louise Robinson, who has the Order of, she's an OBE, she's knighted for her work on post-diagnostic support in dementia. So she's also a brilliant human and a friend. So she's not just incredibly, she's not just a genius when it comes to dementia, but I worked on her Pride In study, and one of the key articles based on that study there that I linked the DOI to is looking at key components of post-diagnostic support for people living with dementia and their carers. So there are a number of different issues of post-diagnostic support. The next slide. So basically, if you go into that article, there'll be a diagram that will talk about all the nuanced variables of post-diagnostic support that people living with dementia in England, Scotland, and Wales would like to see for their dementia experience. When I moved to England, I thought, so when I was doing my training as a gerontology doctoral student in Canada, I was always told that England has amazing post-diagnostic support. If you want to learn more about dementia, go to England. When I moved to England and went on a post-diagnostic support team, the best one in the country, and I'm not bragging, but I'm saying that as this is the best post-diagnostic support team in the country. They were completely transparent of there are many gaps and many barriers to people receiving post-diagnostic support in England. So by no means is it right? Everyone just has pockets of things they're doing right, and we're all trying to learn from each other to deliver a better post-diagnostic support experience for when you do receive a dementia diagnosis. Now, this is a dementia statement. It's developed by people living with dementia and their carers. So what it describes is what people living with dementia have decided that this is what they need and this is what they have rights to. And it's all we statements in this, and it's for people living with dementia, but it's also for people caring and affected by dementia with their families. The font is pretty small, and if you're watching this on a small screen, my apologies. I'm going to read out one statement now just to try and get a little bit of a flavor for what it is. So we, people living with dementia, have the right to continue with day-to-day and family life without discrimination or unfair costs, to be accepted and included in our communities, and to not live in isolation or loneliness. So that is one of 5 of the statements for dementia statements. And we need, as a dementia researcher and advocate, I'm aware of these and need to continue to be aware of them, so I don't further project any stigma or discrimination with my work and collaborations. So the carers and family. So caregiving, these are just a few slides because it's really important to also talk about the family caregivers. And I used to completely focus on caregiver issues. I worked with the British Columbia Psychogeriatric Association on caregiver issues and dementia. But now, more recently, my work is looking at more so risk reduction in dementia. So Alzheimer's caregivers. There are 15 million Americans caring for someone living with dementia. And in the US, unfortunately, these are US stats, there are 17.5 billion hours of unpaid caregivers. 62% of caregivers are women. Like the Alzheimer's Disease International slide previously, 70% of caregivers are women internationally. So vast majority of individuals are women who are caregivers. And there are some more stats from the UK on the right there. I just wanted to point out these slides because I think the numbers are pretty interesting. So 30% of caregivers for people with dementia have been doing so for between 5 and 10 years, and almost a quarter of the people have been doing it for over 10 years. So over a decade of caring for someone and supporting someone living with dementia. And 36% of those carers, again, 60 to 70% of them are women, spend more than 100 hours per week caring for a person living with dementia. And oftentimes the healthcare infrastructure is often the case that those individuals are not reimbursed for their time in any way, shape, or form, and accessing resources to better support their own well-being, as well as the well-being of the person for dementia, is very limited. So there's interesting work looking at cannabis and caregiving. This is in the US. This is by Professor Brian Caskey, who does great work looking at cannabis use. And whenever you speak to him, he will make sure to tell you, look, I'm not a Cheech and Chong person, meaning that is his way of telling people he does not partake in marijuana. He just does marijuana research. And there's a huge amount of research that could be done looking at marijuana and how it affects quality of life of both the person living with dementia as well as the caregiver. Some examples in this article are talking about how caregivers will use marijuana to support the sleep or to help the nutritional value of helping the individual living with dementia to actually eat food if they lose their appetite. It will also help with the reduction of anxiety depending on what types of strain of marijuana for the caregivers. So again, never a silver bullet. This is never a one-size-fits-all thing, and this is never an all-encompassing thing. But it is an interesting piece of work just published a year ago. The DOI is there. So carers in long-term care, so I talked about informal carers, family carers, and now I'm going to talk about a lot of work that I did looking at long-term care settings or nursing homes. And I know nursing homes they were in the news a lot because of COVID, and a lot of nursing home advocates such as myself thought, maybe this will be the thing that changes nursing home reform and we can finally get nursing homes in a way that aren't institutional warehouses, which aren't always the case, but I mean, unfortunately, they are often the case for older adults, specifically older adults living with dementia. So I'll talk a little bit about that and about what's happening. So the reason I bring up nursing homes and dementia is that 2/3 of residents in nursing homes or in long-term care are living with dementia. And this is in all high-income countries. And 2/3 of dementia-related deaths occur in long-term care. So if you have dementia, you're more likely to be in a long-term care facility. And if you have dementia, you're more likely to end your life in a long-term care facility. Esther Brooks in the University of Alberta, her and her team does absolutely brilliant work looking at long-term care reform and care aid work in long-term care settings. They pointed out that over 100 published reports in the past 50 years, all from high-income countries, have been developed, each stressing the poor conditions of care in long-term residential care facilities. That's what LTRC means, long-term residential care. So we have all these reports. We have all these reports from high-income countries, all of them saying, look, things are bad. They're bad for the carers. They're bad for the residents. There's lots of rates of abuse, both on the carers and the residents. It's a grim situation. Something needs to be done, but very little has been done. Also, there's a global shortage of care aids required to meet the needs of an aging population. I first became interested in this work because my mom was a care aide growing up. I spent a lot of time in nursing homes, free childcare. And so because of that, I am quite acquainted with the care aid role. I could never be a care aide. I'm not a good person like that. I do other things. But there's a global shortage of care aids that's needed to support the needs of people living with dementia, especially if we're going to keep on having this institutional care model that we currently have in high-income countries. So care aids provide 90% of the direct care to people living with dementia in residential care facilities. They're also the least researched population, so we know very little about them. So we have this perfect storm of they are the least educated, they are the least, there is no overarching governing body, there is no standards of education in Canada alone, even within the provinces, for what is the scope of practice for care aids. It keeps on changing. Do they deliver this medication? Do they not do they do peri-care? Do they not? I mean, they always do peri-care. So they're the least researched. And so because of that, I did my doctoral thesis on looking at care aids in long-term care settings. I asked a few dozen care aides who worked at a variety of long-term care facilities, up to 30 years experience to brand new educated care aides with 2 months experience, why they chose this career, what was their education like, what are their relationships in the long-term care setting in between staff, management, residents, other care aides. Also, I asked, how do they believe they're viewed in society? So do they think society knows what they do? And I asked them, what do they think are the barriers facilitators to the delivery of good quality dementia care to people in residential care? And I have 2 quotes here. I think they're the most important quotes. So this individual, who's a 50-year-old female with 32 years experience in long-term care, said, I wouldn't choose this work again, because after 30 years of working as a care aide, I feel there is no respect in what we do. And in all we do, we are belittled. And this is from a male, the second quote, with 16 years experience, a 45-year-old male. He said, a lot of people brand us as a professional diaper changer, and it annoys me because there's so much more to it. You're in these people's lives for quite a while, and you see a lot of things, and you can only take so much of it for so long sometimes. I vividly remember both of these participants, and it just came from a point of desperation of, we're doing our best, we're in a situation that is systemically pointed to help us fail by being under-resourced, short-staffed, incredibly high rates of turnover, like I said, barriers to education and resources. And so this is what they feel like. if you want more information about that study, there's this article published last year, and then I'm currently working on an article looking at care aid perspectives for end-of-life care for long-term care settings. So if you want that, just let me know. Okay, so we talked about what is dementia, what are some symptoms of dementia, what is the situation for informal caregivers or family caregivers. We talked about care in long-term care settings. Now we'll talk about prevention and risk reduction. And I think this is almost the last section. There's one more section after this, but that section is quick. I just know because sitting and listening to someone yammer on for an hour is a bit of a thing. So everyone is doing great. So for risk reduction, this is Alzheimer's Scotland does brilliant brain health research. I'll talk about them in a little bit. But there's many ways how to protect your brain. They're really simple too, right? So be active, just take regular attention to your exercise, eat healthy, stay social. So staying social is one where it's so important, but oftentimes you see a lot of reclusive people that actually puts you at higher risk for dementia. I'm a self-proclaimed introvert. I like my alone time a lot. I think that's probably why I moved so far away from my family. I'm just kidding, I love them. But being social is so important for your mental well-being and keeping your brain working, just like running or anything else. Getting creative, avoiding harmful substances as best you can, and keeping rested. A lot of really, really interesting work looking at sleep and dementia. So this is a slide, and the next few slides, if you were in my lecture yesterday, the next 5 slides were a part of that, but I'll just whip through them here. This is a brilliant article. It's the Lancet Commission on Aging from Professor Jill Livingston in London in the UK. And what I want to point out here is that it looks at all the population attributable factors of potentially modifiable risk factors for dementia. So these are all things that you could do to reduce your risk of dementia at different stages of dementia. So at early life, there's education. And I want to pause right there, because if the only thing society did was help everyone become literate, just that one thing, we would vastly reduce that massive amount of 160 million people living with dementia by 2050. So if we just educate people, not just, I mean, I'm sure it's a massive project. It's not my project, that's for sure. But if we just get people to be literate in early life, we would reduce rates of dementia. And I mean, we're not necessarily talking about high income countries here, but low and middle income countries especially, literacy cannot be stressed enough. So moving off that, in midlife, things that can be modifiable that can reduce your risk of dementia are hearing loss, avoiding traumatic brain injury, wearing a helmet, hypertension, alcohol, keeping it to less than 21 units per week. If you don't know what a unit of alcohol is not 1 glass. For example, a pint of beer is something like 3 units of alcohol. A small glass of wine is something like 2.3 units of alcohol. So you can easily get to over 20 units a week, which will increase your risk of dementia in later life. So just to keep an eye on that. In later life, it's smoking, depression, social isolation, physical activity, air pollution, which is super interesting, and diabetes. So potentially modifiable risk factors, we can account to 40%. You'll see in the bottom bubble there, it says risks unknown, 60%. So that's 60% of the risk we don't know about when it comes to dementia. So a huge area of research to look at. So what are we going to find out in the next 5 and 10 years that could be a variable that will increase our risk of dementia? Yeah, it's something to have a think about. And we need more creative minds on this. So not just, academics up in the ivory tower blabbering away. So this is the exact same report. It's the Lancet Dementia Commission, the DOI. That link is there if you want to get it. It's really easily Googleable. It's a big article. It's a little bit boring, but the graphs are really interesting. I want to point out this one quote here, which is in the discussion at the end of this article. It says, "It's important to remember that socially disadvantaged groups, such as members of racialized communities, are particularly at risk of dementia, especially members of Black, Asian, and minority ethnic groups." So that's something to be incredibly aware of. So what happens is current large-scale dementia prevention research, current large-scale research looking at donated brains. Donated brains are overwhelmingly from white middle-class individuals who are highly educated. Dementia prevention research, you'll see on the top there, the participants are from overwhelmingly upper middle-class individuals who are white, who are from urban areas. So we're not getting at rural participants, we're not getting at racialized communities, we're not getting at low socioeconomic status or socially deprived communities. So almost all the dementia prevention work we've done have been in this one cluster of pretty affluent, privileged people. So I've been working on a study looking at how can we get dementia prevention research to be more inclusive to diverse participants. So the issue is, why do we want to do this, is because that marginalized populations, such as racialized communities, members of LGBTQ communities, they are at higher risk of developing dementia, and then they face delays in accessing dementia resources and post-diagnostic support if they do get dementia. So really bad scene. So I'll tell a little bit about this study now that I have. So the PREVENT study is this really massive study. It's actually really cool. If you want to look at the website, the link is right there. It's looking at 700 participants from across the UK. And for the last 10 years, it's been collecting data from them, from lifestyle factors, biomarkers, lumbar punctures, blood, genetics, urine samples. And it's been following this cohort of healthy 40 to 50-year-olds to look at their risk factors for dementia and their brain health. The larger PREVENT study is from Imperial College London, Oxford, University of Cambridge, Trinity College Dublin, and the University of Edinburgh. So I've been working with this study with a small grant from the Global Brain Health Institute to look at how can we make prevention research more inclusive to diverse populations. So how can we get participants that aren't just pretty affluent living beside Cambridge who can roll over and get into the MRI scanner? We need to get more rural participants as well involved, and racialized communities. So again, this is a bit more about the PREVENT study. Like I said, healthy 40 to 59-year-olds. They use MRIs, brain imaging, genetics to track the changes of the brain throughout middle age. And the hope is to find who is at great risk of dementia before the disease can take hold. And before I mentioned how individuals who are marginalized from racialized communities, they're at higher risk of developing dementia. But in all studies, on all prevention studies, unfortunately, the vast majority of participants are a sliver of one of the segments of population. So in this PREVENT study, they're 96% Caucasian individuals. They're high, so less than 4% people who don't identify as being white, all really, really high occupation, highly skilled individuals, and only 15% had less than a university education. So again, a really affluent population. What I did is I interviewed everybody from this study, everybody who agreed to participate, and asked them, why did you participate in research? Why do you think your friends and family don't participate in research? Because they were the only ones in their social groups who did. And I asked them how we could make research more equitable to individuals who perhaps are not comfortable in the institutional setting. This is just one quote. I should say not comfortable in the institutional setting, as well as perhaps not aware of why participating in research and how researchers can make research more inclusive to these populations. So what can we do better? Because the onus is always on us, because we're the ones who are sitting with the grant funding, we're the ones who are sitting in the ivory tower, and we're the ones who have to do better by society. So one participant said, you know, I'm actually not interested in research in particular. If other people are interested in research and I think I can help them because I'm not brainy enough to do that, but if I can help their research, then that's fabulous. And there's a lot of information on this slide, but I just want to point out three things. There's a number of motivators why people participate in research, whether that's altruistic or their own brain health curiosity, or they're just interested in academia and how research works. But a number of the barriers are that people are not aware of brain health research and the importance of participating. Often people will be fearful of participating in research because they don't want something bad to be found out about them. And often people just can't participate in research because they're a single mother at home taking care of 4 kids and they don't have the funding to go and get themselves to a research site and to take the time off work or to take the time off childcare. So there's a lot of monetary and logistical reasons that are barriers to participating in research. Another study that's happening that I'm working on with my colleague, Francesca Farina, who from Trinity in Ireland, we're looking at brain health risk and resilience factors in healthy 19 and 39-year-olds. So we're currently setting up a similar study like the PREVENT study, where we'll be looking at biomarkers and lifestyle risk factors. But we're going to be doing this with younger adults, so 19 to 39-year-olds. We're currently conducting focus groups and consulting groups with younger individuals in the UK, Ireland, and North America to really understand what is their awareness of brain health, resilience, risk factors, to really get at the younger generation population to see if there's anything that, well, there will be things that can be done to prevent dementia in later life, all from earlier and earlier demographics. So that's something I'm excited about. Now, final section, there's about 6 more slides, and they are probably the most interesting ones, but I'm very biased. So this is a project I did with a great group of people in Dublin with the Global Brain Health Institute. What we did is we looked at diversity and brain health issues, and we looked at the perspective from older LGBTQIA individuals in the Irish community. The Irish community it has a very long history of Catholicism. And so even, gay marriage wasn't legalized until so recently ago. So it's really interesting conducting research with this population, and specifically conducting research with this population that is members of the LGBTQIA community in an older demographic. The article's there if you're interested in it. So 3 things that I want to point out about this is that there is no one aging and brain health LGBTQIA experience. Like everything, if you meet one person who is queer, you meet one person who's queer. You meet one person with dementia, you meet one person with dementia. Everyone has their own narratives and identities and experiences. An interesting thing that individuals brought out, and I think this was specifically someone who had transitioned from one gender to another gender, is that some individuals experience dissonance between their LGBT identity and other identities. So for example, we had an individual who described coming under pressure to drop her LGBT identity to be accepted as a grandmother to her new grandchild. So aging throughout the lifespan, although we may like to think we're a diverse and inclusive society, there are several instances, even in Canada alone, where people transition to one gender, but then when they go into a nursing home, they have to transition back into the gender that they don't identify with. So this is incredibly disheartening. In this study, they talked about how healthcare policy and staff inclusion is paramount to having an inclusive society. So obviously have staff trained about what pronouns to use, how people identify, how people would like to identify to maintain inclusion throughout the lifespan, especially if somebody is developing cognitive impairment like dementia. Okay, so that's one study. Another really interesting thing, and this is one of the most exciting things. It's not exciting, it's heartbreaking, but it's also really exciting, is looking at intimate partner violence and gender-based issues. So intimate partner violence is domestic violence by a current or former spouse or partner in an intimate relationship against the other individual. So it can take a bunch of forms, including physical, verbal, emotional, economic, financial, sexual abuse. Dear buddy and friend, or colleague and friend, sorry, Professor Monica Cattins from Australia does absolutely brilliant work. This is something that was just published last month. It was just published last month. So it was a 2022 article looking at a longitudinal study for intimate partner violence and risk mortality in incidence of dementia in older women. The PREVENT study I talked about before also has a brilliant woman, Natalie Jenkins from Scotland, who's doing work looking at longitudinal studies of intimate partner violence. And what her study, it hasn't been published yet, but it's in review, found that individuals who experience intimate partner violence were as or more at risk of developing dementia in later life as footballers. But you know how footballers, they get a lot of media attention for their risk of dementia. Women who are experiencing intimate partner violence are not receiving the same sort of propaganda and support. So it's really something to be aware of. It's absolutely fascinating research too. So as far as research goes, what's something really progressive happening is that there's the DEEP network. So it's UK Network for Dementia Voices. And what they've done is they've given funding and support to individuals living with dementia to support their own research. So people with dementia will apply for funding and they'll conduct their own research projects with the support of other researchers, such as myself or other colleagues who are trained in research. And they've done a number of projects. And if you want to learn more about them, please give them a Google, because it's actually quite interesting, the research that people living with dementia have chosen to do for themselves. And it really disseminates, it alleviates that stigma of prescribed disengagement that Kate Swaffer brought about from Australia, that even though you're diagnosed with dementia, you can still be trained as a researcher, you can still get a PhD, you can still be fully involved in society and grow and develop as a person. This is a project that I worked on a couple years ago with the ORCA, the Ontario Retirement Community Association. It oversees 620 retirement communities in Ontario. And what I did was I had a postdoc with the MITAX group in Canada, and I was funded to evaluate the current state of dementia inclusivity. So I went to a number of nursing homes. I slept over in the nursing homes. I talked to residents, I talked to staff, I talked to management about what their thoughts were about people living with dementia in these settings, how they felt they were being taken care of, supported, or perhaps support could be done better. I then, with the team, developed training for staff, residents, and management. We made a really nice, if I may say so, promotion video. It's on YouTube there. It's just a few minutes long. And it's talking about how an individual living with dementia is seen in a dementia-inclusive retirement community and how it's enjoyable to live there and what people do to make her feel more supported. Because dementia is just one aspect of her life. So this is the final bit. I wanted to bring up these brain health hubs in Scotland. I said I would mention it before. So basically, like here, you have the cancer centers and you have the diabetes centers. In Scotland, what they have is brain health centers. So they're actually standalone buildings you can go into at any age and learn things about how to increase your resilience, your brain health resilience, how to decrease your risk of dementia. I didn't put much there, but you can Google it, Brain Health Scotland, and see what's happening there. I fully realize that Scotland is a smaller country than Canada, so they can promote things maybe a little bit, I guess, easier than across all the provinces and healthcare systems we have. But it's a really beautiful model for what can happen in the future for Canada as well, to have these hubs of brain health education awareness. This is their newsletter that came out actually last night, so I just wanted to throw it in there. So every month they have a new newsletter talking about the best place for news and advice on how to keep your brain healthy. So you can easily sign up for that. And I know the founder of it, Professor Craig Ritchie, and he would be happy if a bunch of Canadians signed up for that. So wrapping up, we discussed the dementia overview, risk factors for dementia, being a family carer, a formal carer, how to reduce your risk. I think that's it. I think I've talked for what feels like years. These are the resources that I was telling you about. I took time into curating what ones I thought would be the most useful for everybody. So there's the Canadian ones on top, the international ones in the middle, and then the ones for lived experience. So if you're living with dementia, I highly suggest that one there, Dementia Alliance International. Or if you're a care partner, I highly suggest TIDE there in the UK. None of these people fund me, so I don't I'm not promoting them because I'm getting anything. But I think they're really good. And if you want more, please let me know. Okay, that was great. Thank you so much. No, hold your applause. I think we'll do questions and answers now. Or we'll just do questions, we'll see what happens.
Thank you, Laura. So just a reminder, if you do have questions, if you want to put them in the Q&A section. And Laura, just to get you started, could you do a brief description of what an anticholinergic drug is? Yeah,
definitely. So starting off with a good question. So I am not a pharmacist. I'm not a physician. I'm a social gerontologist. So an anticholinergic drug there's something that prevents, cholinesterase in the brain, which is supposed to be something that increases plaques and tangles in the brain. And so an anticholinergic drug is something that's going to hopefully prevent that from happening. If you're talking about the slide where I talked about Professor Grace Jackson's work with anticholinergic drugs, if you Google that, what was the title of the book? Drug-Induced Dementia, Professor Grace Jackson or Dr. Grace Jackson. There'll be a list of anticholinergic drugs there, and there's such things as like, what were they? Drugs for, and I don't even want to say them because I don't want to spook anybody, but if you are interested, give it a look, but I don't want to say specific drugs because I don't want people to then go off any medication. I don't think that would be very clever. I am not a clinician. Like yeah, you see the work I do. That's not in that realm. If you want more information about that, I'm connected with Dr. Grace Jackson. She's really pushing out some really good new stuff. So please send me an email. And if a number of people send me an email, please be patient with me responding to you. I'll do my absolute best, but I next week I'm at UBC and then I go back to England. So I'm in a little bit of a whirlwind right now. So any delay isn't because I care. It's just because my inbox is a screaming nightmare. Is there another question?
Yes. So do you have any thoughts or knowledge on psychedelics, for example, psilocybin as a treatment for Alzheimer's disease or for brain health in general?
Yeah, I know actually Vancouver Island University just down the road in Nanaimo is doing really interesting work looking at post-traumatic stress disorder and mushrooms. I can't pronounce the word, so let's not butcher it. But yeah, they're doing really cool work looking at mental health and post-traumatic PTSD, and I think it was frontline workers for, I forget what it was, but they're doing really interesting work there. The problem with Alzheimer's and dementia is that, so if you take a hallucination, you're doing something to the brain where something's happening, right? And I'm just doing this because it's a lack of words that I can't describe it. It's like when you do, what is it called? When you, electric shock therapy, right? You can't fully describe what's happening, but you have a shock to the system, like you reboot a computer. So psilocybin could be something like that, where you're kind of rebooting your brain, but not rebooting it, but moving it in a certain way. And again, this isn't my area of research. So anybody in the audience who knows more about this, like drop a name in the chat and we can Google that person later. But yeah, I would be hesitant to see how that would work on Alzheimer's and dementia, because with Alzheimer's and dementias, you don't need your brain shooken up more. It's already suffering, right? You need something to rebuild those neurons and to decrease the atrophy already happening in the brain. So I don't, I'm openly not an expert in that area, but it wouldn't be something I would immediately go to. And I love that research. I love illicit drug research, and I would be open to looking at it more, but innately, it doesn't sound like something that would work.
Okay. This is a fantastic compilation and summary of dementia research. So nice compliment.
Thank you. Let's leave it at that.
Is it possible to diagnose dementia in an individual before onset?
Well, do you mean, is there a clinical test or a biomarker to show if you'll get dementia? Is that the question? Probably right, Joanne?
I think.
Yeah.
So.
Yeah. So the answer is it depends on what type of dementia you have. Some dementias, like certain young onset dementias, will have a really strong genetic component, and you can test for if you have that gene. And then if you have that gene, there'll be a higher likelihood of you'll get dementia. But in the general population, you can see if certain, so like apolipoE, if that will link you to getting dementia in later life. And I'm sure I butchered that word as well, and my colleagues would make fun of me about that. But again, I'm a social gerontologist. I'm getting all these biomedical questions. But that's okay. I prepped for this. No. So even if you do test for getting dementia, like let's say there is a test for getting dementia, and I can take the test and I can see if I'm 50% more likely to get dementia in the next 50 years. Am I going to take that test or not? Why would you take that test? You would take it to get better prepared for what it could live like with dementia. But would you take that test to then have kind of a negative outlook on the future that you may or may not get it? Or would you take it and live life to the fullest, knowing what you know? In the PREVENT study, I ask everyone if there was a test and if there was a way to show your exact percentage risk factor for getting dementia in midlife, would they want that? And it's an equal split of people saying, no, I don't want that. Keep that information away from me. I'm living the way I'm living now. I'll get it or I won't get it. And then another group of people saying, I want all the information. I want it 10 years ago. And why don't I have it now? So I think it's very individualized. And what prevention researchers are talking about now is, I forget what the word is, but when you prescribe something and you're looking at individualized prescription, I know there's a word for that, but it's just slipping my mind right now. But it's looking at that nuanced kind of feedback of giving people that. I hope I answered that question correctly.
Along the lines of personalized medicine.
Yeah, exactly. Personalized medicine. So that would be the same thing for personalized risk factor assessment. So seeing where you are. So if if somebody like named Kim was at a risk factor for dementia, and we looked at all her lifestyle risks, and then they could do an algorithm, which they actually have an algorithm. It's really interesting and over my head. And they could be like, okay, so Kim has these and these lifestyles. This is her family history. This is her genetic, her blood, her urine, her biomarker, everything for dementia. She is at X risk for these dementias. Then it would be a personalized description of, does Kim want that information or does she not want that? A blanket will tell you or we won't tell you, or here's a gene and you can go get it. I don't think is wise for society right now. There's too much stigma and there's too much people deciding to die by suicide rather than living with dementia. I didn't put this in my slides, but there's a brilliant website called Death by Noon by Gillian Bennett, who's a woman in British Columbia who chose to die by suicide at noon on a certain day rather than live with dementia. And this was about 10 years ago. So society does not need more things getting people fearful of getting dementia.
Mm-hmm. Is there a connection between ECT and early onset?
Electric shock therapy?
Yeah.
No, I mean, actually, not that I'm aware of, but again, that's not my issue. I mean, it's not my issue. Wow. Can we not put that on YouTube? That's not my area of expertise. So I don't know if there's a link. I would have to look into that for you. I've got a bunch of colleagues that look at young onset dementia. So I could look into that and give it and fire an email off to somebody, but off the top of my head, I have to openly say I don't know about it. That doesn't mean it doesn't exist.
And could you repeat the name of the journal that you mentioned? I think that was towards the end there.
The journal?
The one out of Scotland, I think.
Was it the journal? Was it the Brain Health Hub Scotland? Or was it a peer-reviewed journal that I talked about? Because I talked about a number of peer-reviewed journals, and I'm sorry, I would throw the links in the chat, but that's not how webinars work. I'm not allowed to do that. But if it was Brain Health Scotland, you could Google Brain Health Scotland, and then the website will come up. It's lovely. They have a great web designer. You just put your email in for the newsletter, and then you get the newsletter every month or so. And it will also keep you aware of what dementia research is happening in the UK. And I think really, if with anything with this lecture, if you know people who have the privilege of having the time to be able to participate in brain health research, please, we need more people involved in research. It can't just be the same people that, yeah, that's all.
And this may be from the same person that asked about ECT. There's a comment saying, having received ECT myself, I would absolutely say there are effects on memory. I was recently diagnosed with MCI.
Okay, interesting. So the other thing is that when people go under, so when people, and lots of examples of this in different medical situations, when something happens to the brain, sometimes the brain can't come back to its current state. So what often happens, and I've got many anecdotal and many academic examples of this, is that if people are put under for a surgery in later life, or sometimes even like in later midlife, when they come back, their brain, something is different. So whoever said that about ECT, first of all, thank you for being brave enough to share, and thank you for being comfortable enough to let us know about this. You've put it on my radar. I'm definitely, as soon as I have access to Wi-Fi again, gonna do some research for myself. And yeah, I think if that's your lived experience, then 100% I like, I'm sold. I now agree. But I just don't know the academic literature, so I don't know, and I can't vouch for it.
When you did your research with care aides in long-term care homes, what were some things they said that would help them with their jobs?
Oh, and honestly, my PhD is so grim, like it's so depressing. I think that's why it took me 80 years to do it. But it was like, honestly, so care aides, what would help them do their job better would be if we had a standardized scope of practice, not just for British Columbia, but for Canada, and then ideally North America, and then ideally Western societies. So we have an actual definition of role of what their scope of practice would be. We hire people who are equipped to do the job at hand. I openly said, I can't be a care aide. I can't, like, I don't want to touch anybody. I can't touch people. Why would I be a care aide? I'm a researcher. So you need to hire people who can actually do the job. You need to hire enough people. You need to pay them well. You need to have a scope of practice and have an education plan that matches the scope of practice. So instead of people getting into the long-term care setting after 3 to 9 months or 1 year of training and literally telling me things like, I can't believe I'm doing this to a dead body. I had no idea what to do. I had no idea how to deliver X amount of care. That would be a brilliant thing. The other thing is care aides have the highest rates of injury and burnout and turnover than any other healthcare profession. So we need to be able to kind of set up an infrastructure to support them for the role. And in society, they feel, and this, I'm not swearing, but they swore, so I'm blaming this on them, but they felt like society just saw them as ass wipers. And if that's how we see the person delivering the most direct care to the most vulnerable populations living with dementia, that's on us as a society to fix that and to learn more about what is the care aide role and what can I do to support it and lessen and destigmatize it. It was a ramble, but I really do care. I care about a lot about that. I don't do that research anymore, but I still care.
Do you know of any studies around worsening of dementia symptoms once people enter the long-term care?
Yeah, 100%. It's actually like, yeah, because when you go into a long-term care, so a quick answer, 100% yes, lots of studies. There's lots of studies that look at how quickly end of life happens once you enter a long-term care facility. Long-term care facilities are, and I'm not bashing all of them, and I'm sorry if what I speak to is a generalized and is a dark generalization about the system, but yeah, I've done this research for a long time and it's not always positive. Unless you can afford an incredibly posh, like, private long-term care facility, and if you can, fair play to you, but that's not always the situation for society. Yeah, people definitely, their cognitive abilities can go down because you're putting them in a setting that they know, their brains know the patterns of the door is here, my kitchen is here, my daughter is here, the foods get fed to me here, this is what I eat. And now you're in a brand new setting and your poor brain that already has cognitive incapacities with dementia is now being visually stimulated, auditory, you're smelling different things, visually, everything. Like your poor, like I cannot say it again, your poor brain is suffering. So although there may be some benefits, as in you have direct care, that's a massive benefit. You have people around you, you have the social aspect, massive benefits. The other logistical issues that would affect your symptoms could be at play. So not always, but yes. Good question. All the questions are good. No more questions.
We have a respondent that says she's 82. I need social contact, but don't like stuff at senior centers. Doesn't have any friends left. Should I bite the bullet even if I don't like their activities?
No, you're only 82. Don't you're 82 on this webinar listening to me yammer about. I'm sure there's other fun groups out there that aren't just bingo in some long-term care facility. I get it. And I've got a bunch of friends who do rec therapy in long-term care, and I've helped educate staff in rec therapy and long-term care, and intentions are good, but resources are small. So you can only do what you can do. I think that's a longer conversation about moving into long-term care. I don't think I can advise you, even though I said no, that came from a place of, no, don't do anything you don't want to do. Like you sound like you're a great person. So follow your heart with whatever sounds better. But as far as fun things to do, I know everybody is just dying about online things. Like we don't need more social activity online, but no, and I don't know if you live in a remote or urban setting. And I know that perhaps if you talk to a physician, I don't know what they would tell you, if they would suggest something else, but don't make one massive life course decision based on one tiny thing I said about social interaction and long-term care. Yeah, I don't know if I answered that correctly, but I feel like that's a longer conversation to have. But yeah, don't do anything. Don't bite any bullets. You don't need to.
Well, one of the other participants has suggested that requester volunteer their time.
Yeah, 100%. So the peer mentorship program that I have, it's for people with Lewy body dementia, but it's linking up mentors online with each other. The Tide group I posted in the slide before this, here, just one sec, the Tide group there. So the very bottom thing, it says for care partners, Tide group. They link in care partners that are isolated at home online. There has to be something in Canada and British Columbia that links people, older adults, with one another. You can be trained up to support somebody for whatever your lived experience is, and support people in that way. But is there anything else? I'm getting, no? Okay.
Can you quickly recap the prevention factors?
Yeah, 100%. Here, just one sec. Don't look, look at me, don't look at these slides. There they are. So here are them. So, but there's a number of, so there's the two slides, right? There's this one, so stay rested. I cannot stress sleep enough. It drives me mad when people say, oh, just sleep less. Don't sleep less. Your brain needs sleep. Sleep more. Sleep is lovely. I love sleep. Get creative, learn. To the individual who just said that they're lonely, I do this comics and medicine drawing thing once a month. If you want, you can join me on that. It's just like going to this group of, they're really interesting artists, and we just draw together for an hour once a month. And because I moved to the UK in a pandemic, I had no friends. It was incredibly isolating. So I can't draw, but it is something to do once a month that I look forward to, where I can see humans and they can see I'm alive. And have a cup of tea with them. So get creative, avoid harmful substances, be active, eat healthy, stay social. And I mean, do the best you can do. Like if you're a smoker and you've been a smoker all your life, and it you know it's not the best health-wise, but like things happen, right? I only know one language, and that's not good for the brain. You should learn an instrument, another language, and I've known this, for 15 years, and look at me not learn another language. The other thing that's interesting, so there's that, but then this slide is the really, really interesting one with the more nuanced modifiable risk factors that you can have autonomy over. Hearing loss is really interesting. So yeah, because hearing loss is just like learning another language, right? So if you hear things, your brain is working in that way, but if you're seeing things visually, the brain isn't working in that way, it's working in another way. Anyway, sorry, Joanne.
No, it's okay. Because I lost the comment on a platform. See if I can find it.
Thank you everyone for staying on this lecture and asking questions, and for listening. And yeah, if I can be of any assistance, please let me know. Just be patient.
So I know someone asked about accessing the slides that Laura's shown. I'll have a discussion with Laura about how we might be able to make that available to attendees, because as she said,
It'll be on YouTube.
The YouTube, yeah, oh right, on the YouTube when we.
Yeah, but if people want the actual slides, maybe if you really have a hankering for the slides, could they email? Yeah. And I can send you the PDF copies.
If you're willing to share it.
Yeah, no, I'm not precious about any of this. I lifted most of this from people who are smarter than me. So let's just all pass it around. I'm gonna go back to the resources though. Sorry. There. I think we're almost.
Sorry, I'm just looking for the one because it was For someone looking for to help reduce social isolation, one of the participants has suggested a platform called Amintro, AMINTRO. So AM as in mother, IN as in Nancy, TRO, a platform to help reduce social isolation for 50 plus. And the demographic based, 50 plus demographic based on friendship.
That's brilliant. You know what we could do? We could do, as if I'm going to be helpful at all, is put that link at the bottom of this YouTube. Maybe somebody in the chat or somebody could do that when this gets posted, because I would also like to know that. And my apologies for not knowing that, but I am human.
Well, it's a free platform.
Cool, cool, cool.
Does anybody else have any questions or comments for Laura? And I will make sure that Laura gets all your compliments that you've had.
Oh, that's so nice, you guys. Thank you very much. I appreciate. Sorry if I said anything offensive. I tried really hard to not to say anything. Okay, I think it's about time we should end this.
Let me just do a quick here.
Okay.
I think we've got everything. If we've missed it, please email us at the Institute on Aging and Lifelong Health at UVic, and we will pass your questions and comments along to Laura to try and address offline. Also look for some additional information once we decide what we're going to do about the slides. But as we've said, the webinar itself will be on the YouTube channel. So, and we'll put that up onto the Institute's website as well. Thank you very much for attending today. Really appreciate your participation and all of your questions.